hair loss of the scalp, asymmetry of facial features, and if there is asymmetry, does it affect the whole, what part of the face does it affect? Just one section of it or the whole side? And again, we'll learn about that later, testing the cranial nerve 7. Any facial tics or odd, contractions, and then any other abnormal facial features such as edema or swelling, prominent eyes like we talked about yesterday, coarsened features, hirsutism, abnormal hair growth, especially in a woman, or if they just have lack of expression, excessive perspiration right here, and pallor. All right, you're also then going to palpate. Palpate the skull. You're just going to, put the fingers and just kind of gently, with rotation movements along the scalp, kind of from the front to the back. Again, feeling for any abnormal bumps, tenderness, swellings, depression, anything like that. And as you can kind of move your scalp over the skull, and it should be able to freely move like that. The hair, you're going to palpate the hair and feel for the texture. Notice any thinning and the distribution of the hair. The temporal arteries. If temporal arteritis is when you have a lot of inflammation in that temporal artery, it should be firm to palpation and tender, so you want to make sure that's not there. And you're going to also palpate the TMJ, temporomandibular joint. Okay, and to do that, we're checking for crepitus, kind of that grinding sound and sensation. I probably have it in my knees. Now, first of all, what you're going to do is just place your fingers right in front of the tragus of the ear. The tragus is this little bump right there. Put both fingers there, have the patient say ah or open up their mouth, and then from side to side, and you're just going to feel for that kind of grinding sound. Now, it's not unusual to get an occasional popping, but it shouldn't be painful or have that kind of grinding sound. Those could be signs of TMJ syndrome. And there is the tragus there. We'll talk about that, or more the features of the external ear here. And there's someone performing that. Okay, so the external, again, you've just gone through this. The external ear is called the auricle or the pinna, as well as the external auditory canal, or EAC. The middle ear is this air-filled cavity in the temporal bone. It contains the 3 ossicles, okay, the 3 little bones, smallest bones in the body, the malleus, incus, and stapes, and the sound waves go through the ear, hit the tympanic membrane, gets vibration going in the tympanic membrane. Then the vibrations continue through the bones, the 3 bones, and on into the inner ear. And then the inner ear consists of the vestibule, the semicircular canals, and the cochlea, and then eventually, once those sound waves or the vibration gets to the cochlea, then it goes up the cranial nerve to the brain, temporal part of the brain, where it's, what's the word?
Interpreted?
Interpreted, thank you. Did you say that, Zach? Oh, thank you. Okay, so here's the external anatomy of the ears. I would like you to know, especially if there's a lesion on the ear, just saying there's a lesion on the ear doesn't quite narrow it down well enough. I'd like you to know the helix, the antihelix, the lobe, the auricle, the tragus and the antitragus. I'd like you to be aware of what those anatomical positions are. And here is a diagram of the outer ear, the middle ear, and then the inner ear. Okay, so we're going to now examine the ears, examine and inspect and palpate. We're going to inspect for the size, the shape, again the symmetry, any unusual landmarks, the color, and the position on the head. And we'll talk about that here in a second. We're also going to palpate around the ears and back, and don't forget to look back behind the ears and palpate the mastoid bone, again, looking for inflammation, pain, tenderness, things like that. And you might even kind of pull on the auricle. That shouldn't normally be tender or cause pain. If it does, then that could suggest inflammation or infection of the external auditory canal. Like swimmer's ear, if you ever had that as a kid or recently, that will cause quite a bit of pain. Okay, so there's someone examining the ears, looking behind the ears. Talking about the ear position. To kind of get an idea if the position on the head is correct, you're going to draw an imaginary line from the lateral canthus of the eye to the most prominent aspect of the occipital bone. The top of your ear should hit that line or be above it. If it's below that, then those are abnormally low-set ears, and there are certain genetic conditions that can cause that. The other thing too is if you have a perpendicular line right in front of the ear, it should sit up right against that. Sometimes ears are kind of angled backwards. I'll show you here. So here's a normal attachment where you have the line from the eye to the occiput, and then the perpendicular line, the ear sits right along that. The second one, you have that ear where it's deviated backwards, and then you have the low-set ears. Is it, who has the low-set ears? Is it, do what?
Are you thinking of Down syndrome?
Yeah. I think Down syndrome kiddos have low-set ears. Some other abnormal, just variants, they're not worrisome really, that you may find around the ears is this, called a pit or a preauricular sinus. Now, I have seen where, this is just a genetic thing, people are usually born with this. I have seen where these will sometimes become infected. You would want to though, you would want to refer them on to ear, nose, and throat for surgery, because the only way to get rid of that is to do surgery on that. It's not anything I would want to tackle. And then there's something called a Darwin tubercle, which is just a thickening along that upper part of the helix. Again, this is just a normal variant that some people have. Cauliflower ear. Who gets cauliflower ears? That's right. That's just repeated trauma, and they get inflammation and eventual necrosis of that cartilage. And that's a permanent thing. I've seen some drug reps with these big old cauliflower ears. I'm like, what'd you play in high school or college? Okay, here's our otoscope. Very similar to where the bottom aspect is what you saw yesterday with the ophthalmoscope. This is just a different head. On the tip, that's called the speculum. If you buy your own otoscope, ophthalmoscope, it will come with a certain number of plastic speculi, I guess. But most clinics will have just disposable ones. You'll grab one, put it on, examine the ears, take it off, and throw it away. So, well, Miss Reggio will probably show you a little bit more about that. Okay, so we use the otoscope to better examine the external auditory canal and that middle ear. You want to use, usually there's different sizes of the speculum. Kiddos, you're going to use the smaller one. Adults, generally, you're going to use the larger one unless if they have just a real narrow EAC. You're just going to, with this one, I always use my right hand. I'm right hand dominant. So I will always use my right hand, and then I use my other hand to pull on the ear. You can either hold the otoscope in a kind of a downward motion or an upward motion. It doesn't matter, whichever one you feel comfortable with. You're going to use your other free hand to support on the head or face, but generally the head. And then you're going to gently pull on the ear up and out to help straighten that ear canal, because it's kind of angled a little bit downward. So you're going to pull that up, gently place the otoscope in the EAC. The EAC is very, very sensitive. So if you get too ramroddy and hit the canal, the patient is going to jump and let you know. For children, though, you want to pull more out or down because their canal is angled a little differently. Okay, we already talked about that. So when we're putting the the otoscope in, we're going to be observing the canal, looking for foreign bodies, discharge, redness, swelling, lesions, cerumen, or earwax. That's a fancy word for earwax. We expect to see the skin to be pink. You're going to see some hairs in there, especially on the outer part of the canal. And earwax, more likely, you're going to see some earwax, and that can vary a lot in how that looks. It can be yellow and flaky, or it can be brown and kind of sticky, or it can be like dark brown, almost black and hard. When you'll probably learn how to irrigate the ear to help wash out some of this earwax, and it will just, when you get a hard plug, it's like a plug of earwax, it looks like a pencil eraser. I mean, it's hard. You can throw it against the wall. So here's someone using the otoscope, and again, kind of pulling out and up on that ear. So like I said, when I'm working on a person's right ear, I'm using the scope in my right hand and pulling up here, but when I'm on this side, I personally still use my right hand for the otoscope, but I just kind of reach around and do that. But you can switch hands if that's comfortable for you. Okay, there's someone examining. You know, you'll get a feel for how deep you go, but you have to get in there about 1 centimeter to be able to see things. I've seen some students just barely put it in there, and there's just no way you're going to see the tympanic membrane. But you also don't want to go in too far because that's going to be uncomfortable. But the patient will let you know. Okay, looking at the tympanic membrane, or the TM, again, we're looking for certain landmarks that we're going to talk about, the color of it, any perforations or holes in it. A central part called the umbo, which is where the malleus meets up with the eardrum. There starts a light reflection, okay? And we call that the cone of light. And I'll show you a picture here in just a second. That cone of light angles downward and anteriorly, okay? So it's always going to point forward. The color of the tympanic membrane is kind of a pearly gray, and it should be somewhat translucent. It's not completely clear, but you should be able to see through it. Your landmark should be visible, and I'm going to show you here, here in a second. If the tympanic membrane is bulging, meaning there's something, some fluid or pus or something like that within the middle ear, and it's bulging that tympanic membrane out towards you, that light reflex is going to look different. And the same thing goes, if there's a lot of pressure in the middle ear, the eustachian tube is not acting correctly, it's going to be kind of sucked in more, and you're going to see the landmarks, and they're going to be sticking out more, they're going to be more prominent, and again, that light reflex is going to be distorted. All right, so this is what your eardrum looks like. All right, so you can see the umbo, and from that, you see the cone of light. You see that? And so you know that the person's face is over here, over here. That makes sense. I'm sorry. Then you have the short process of the malleus. That's another prominent thing you're going to see. Most of the tympanic membrane is rather tense, or pars tensa. They call that the pars tensa. That's the lower half, or not even half, lower big chunk of it. And then there's a less tense area that they call the pars flaccida up by the short process of the malleus. Okay? So be familiar with those landmarks and the cone of light, and kind of which way it's supposed to. Okay, sometimes too, we will evaluate how mobile the tympanic membrane is. And this is usually when you are curious as to whether there is an infection or fluid back behind the eardrum. What we use is a pneumatic attachment, and it's usually, okay, there it is. That's the pneumatic attachment. It's got a tube with a little bulb where you can push air in and out. Or I have seen my daughter's pediatrician had pretty much the same thing, but it was a longer tube, and he just used his mouth and would blow air into it. Or if you don't have those, sometimes you can have the patient just hold their nose and blow air, which should move the eardrum as well, as long as the eustachian tube is paid. Okay, so when you insert the scope, but you need to make sure you have a good seal. So again, you need to use the largest speculum that you can use to completely block off that canal. You're going to apply gentle pressure on the bulb, which applies positive pressure, and then let go, and that is negative pressure.